Hi, my name is Matt Budoff. I'm a cardiologist and principal investigator here at the Lundquist Institute. I wanted to just ask you to spend a few minutes with me learning about some of the misinformation related to heart health and some of the things you can do to live a longer and healthier life.
Okay, I think we're going to go ahead and get started. Welcome to Science and Your Health. As some of you knew this as Lunch and Learn, and we decided to make it really speak to what we do here, which is translational, not only medicine, but bring discoveries really from our labs to the patient, and also from obviously the hospital to our labs to begin some of the discoveries that we need to do to improve the health of everyone here, our community, the nation, and beyond. So we are so fortunate today to have Dr. Matt Budoff speak to us. He is a professor of medicine at the David Geffen School of Medicine. He is also the endowed chair of preventive cardiology here at the Lundquist. I know many of you have heard him speak any of a number of times. He's nationally and internationally known for his work, especially in the use of CT to be predictive of cardiovascular disease, and then can really customize therapies and measure this over time. So we're very, very fortunate to have him. And let's give a warm welcome to Dr. Matt Budoff.
Thank you. Well, thank you all very much, and thanks for coming out today. I'll take you through a brief kind of overview of where we are with prevention and longevity when it comes to heart disease, and then obviously I'll leave plenty of time for questions. When we talk about who's at risk of heart disease, and we have to remember that it's the #1 cause of death for both men and women in the United States, and it has been for a long, long time, that these are the kind of the traditional risk factors that we think about when we want to know who's at increased risk of having a heart attack and who's not. And obviously family history, we've done a lot of research here as well. Dr. Rotter and others have done a lot of research into the genetics of heart disease, and we're still learning about that, but we don't really have exactly a way of testing the exact genetics of saying, did you get that gene from mom or dad? But if your parents, or so we go one generation up or sideways or down. So it's your parents, your siblings, or your children have early heart disease, then you have a genetic predisposition to have early heart disease, and that's how we establish family history. A lot of people do it wrong. They're like, oh, I had a patient today in my clinic. He's like, oh yeah, my grandfather died at age 90 of a stroke. So that's not a family history of heart disease, because we're going to die of something, and a stroke at 90 is actually probably pretty darn good, outliving the average life expectancy for a male by a number of years. So it's a premature history of family history of premature heart disease, and that could be a stroke or a heart attack or cardiac death. Diabetes is the big one. Obviously, there's wonderful new therapies for diabetes, but it increases your risk of plaque buildup in the arteries, and it causes heart attacks and strokes. And most patients with diabetes, about 80% or more of patients with diabetes, will die of cardiovascular disease. So it's what kills patients with diabetes. Cholesterol, you've probably heard a lot about over the years. I'm not going to spend a lot of time today talking just about cholesterol, but there's bad cholesterol, the LDL, or low density cholesterol. That's the bad stuff. And then there's the good cholesterol, the HDL. So if your bad cholesterol is high, your LDL cholesterol is high, that's bad. If your good cholesterol is low, that's bad because you don't have enough. And think about HDL, or the good cholesterol, as the garbage trucks. They're the ones that go around and pick up all of the bad stuff in the periphery and bring it to the liver for disposal. And if you don't have enough garbage trucks running around, if your HDL is too low and you can't get that cholesterol back to your liver for disposal, it builds up and it accumulates and it causes trouble. So either too much trash, the LDL, or not enough trash collectors, HDL, are both risk factors for heart disease. Smoking is bad. I think we've learned a lot about that and have made a lot of huge strides in decreasing smoking. California took a unique approach to getting rid of tobacco. Not only did we raise the taxes on cigarettes to try to make them unaffordable, but we legalized marijuana to get people to switch over. So probably better for the lungs, although I'd have to ask Dr. Cassaberry here about that. I believe it's probably better for us to, anyway. So tobacco use causes a lot of problems. Lung disease and lung cancer are probably number one, but certainly has a big impact on the arteries of the heart and can cause a lot of heart disease. High blood pressure. In the 80s, we called it the silent killer. People were walking around with crazy high blood pressures, and most people ended up dying of a stroke with high blood pressure. I was at a meeting over the weekend, and they had a picture of some of the World War II leaders getting together, and their average blood pressure, including FDR, was like 190 over 120. That was like of the three of those senior leaders in World War II, their average blood pressure was like 190. And when these people finally succumbed to heart disease or a stroke, their blood pressures would often go up to 300 millimeters of mercury because we had no blood pressure therapies back in the day. So we now luckily have a lot of good treatments, and it's hard to go to a doctor without getting your blood pressure measured. So there's a lot more awareness of hypertension. And then obesity and physical activity, we've made some incredible inroads with obesity lately. All of those new drugs you've heard about, Mounjaro and Zepbound, and every company I know of now is going into the obesity business. So there'll probably be, in the foreseeable future, maybe 8 to 10 different products for weight loss that all impact the heart in a very positive way. So we have our traditional cardiac medications, what I call the ABCs. So if you have high risk for heart disease, in other words, you have a bunch of things on that previous slide, you have a family history, or used to smoke, or high blood pressure, or diabetes, high cholesterol, or you have established heart disease, we do the coronary calcium scans to look into the heart to see if you have early heart disease. Then we know that you have plaque, and now we need to apply therapies. And the therapies are literally as easy as ABC. And the alphabet actually goes a little bit further than ABC, but we'll start with these 3 letters and work our way through. So A is antiplatelet therapies. That's good old aspirin for most of us. And aspirin has gotten confusing because for a while everybody should be on aspirin, then for a while nobody should take aspirin, and now we're saying, well, some people need aspirin, but I still use aspirin in my high-risk individuals. And where most drugs are more is better, aspirin is specifically not. So if you take too much aspirin, not only do you get problems with your GI tract, you get bleeding in your stomach or ulcers, gastritis, but it also imbalances the hormones in the body and can actually cause harm. So 325 of aspirin, a full aspirin taken every day, is worse than 81 milligrams of low-dose aspirin. So when we first learned of this, we always told people, oh, just take that baby aspirin. You remember those little St. Joseph's, those little pink aspirins. Take a baby aspirin every day. And then ultimately Bayer and all the other companies came out with low-dose adult aspirin. So we don't have to tell adults to take a baby aspirin. But literally, it's a baby aspirin was the right dose for prevention of heart disease. And it lowers your risk of heart attack, stroke, and cardiac death by almost a third just by being on an aspirin tablet. Not everybody needs it, and not everybody should be on it because it can cause the side effects and the bleeding. And if you don't have those risk factors and you're not high risk, we don't want you on aspirin because all you're going to get is the side effects, the bleeding, without the benefit if you're not at risk of heart disease. For anybody who's had the coronary calcium scan, we universally recommend it if your score is above 100. So if you have enough plaque in your coronary arteries, calcified plaque, to have a score above 100, those people universally are recommended to be on aspirin unless they have some reason they're allergic to it or have some bleeding problem. B, blood pressure is a lot easier because everybody should have a lower blood pressure, and generally lower is better. So we want to get the blood pressure down, and we've learned a lot over the last 10 years even. While blood pressure's been around forever and we learned about it in the 80s and started focusing on it in the 80s, it really, over the last 10 years, we learned a lot about blood pressure, and we learned that it's really better to push that blood pressure even lower. So guidelines as recent as 5 years ago say we need to go even lower than we used to. And you've heard of 120/80, 120 millimeters is the top number, 80 is the bottom. That was our definition of normal. If your blood pressure is 120/80, we'd pat you on the back. Our new guidelines say if your blood pressure is 120 or 80, if either of those numbers exist, that's actually stage 1 high blood pressure. That you should be below 120 and below 80 to be normal. So what was normal is no longer even considered normal. But 120/80 is still a good number, but that's considered borderline hypertension at this point. And lowering it lowers events, and the more we lower it, the more events go down. Blood pressure, think of more stroke. Cholesterol, think more of heart attack. But both of them obviously are terrible endpoints for patients. Cholesterol, we have not only the statins, the cholesterol pills, which have some controversy and have gotten different, maybe even political views, although Trump takes a statin, so that's well disclosed, so it shouldn't be a political thing, but there are a lot of anti-statin people out there now for different reasons. But statins universally in every trial ever done, and many of them by organizations that are not related to pharma, because remember, there's no more pharma income from statins. Nobody makes money on statins anymore. They're $3 a month at CVS or Target, and they're not even sold anymore by companies like Pfizer or AstraZeneca. So we're talking about just the benefit of statins as a generic drug, but they're universally recommended in every guideline for heart disease to reduce your risk of heart attack, stroke, and death. And of the three, they have the biggest impact on death. They reduce cardiac death the most of the three. So I spend a lot of my time, including my time this morning in my own clinic, trying to make sure that people are willing to take them in some capacity because of the benefits that we know exist from statin therapy. And they're not for everybody. Some people get side effects, some people get issues, but they universally lower your risk of heart attack, stroke, and death in every study ever done, going back now to 1985. So we now have 40 years of data with statins. So aspirin has been somehow challenging, but this I like, just Moses receiving these aspirin tablets from God. Bayer used to advertise back in the day that aspirin had, you can see the little aspirin ad, and at the very bottom, does not affect the heart. That was their big claim to fame, that it does not affect the heart. And then Bayer came around, and same company, and started saying it is the wonder drug for the heart, as we learned about it. Now they call it the wonder drug. And it's still very, very good for the heart, but we have to keep in mind that again, there are side effects and bleeding from aspirin, so it's not quite for everybody, and we're going to be putting it in the water supply. But from a patient who's had heart disease or a patient who's at high risk of heart disease, it is still highly recommended in our guidelines. So we have a lot of data from very large trials. These are 16 different studies, and they universally show that they reduce your risk of dying of a heart attack, of having a stroke, of having a MI. All of these things are beneficial in the setting of aspirin therapy when we compare it to placebo. And again, now these are everywhere. It's hard to not to go into any gas station or 99-cent store, I guess they don't exist anymore, or any Dollar Tree or whatever those stores are, and get a year's supply of aspirin for $1 these days. So aspirin is both universally available and very, very inexpensive, and that makes it a great therapy for preventing heart disease. But it's still, in many doctors' minds, a coin flip, and that's largely because of a group of doctors that kept putting out conflicting recommendations for aspirin, and it was very unfortunate. But there's a very powerful group of doctors called the U.S. Preventive Task Forces, and they used to say it was universally recommended. Then they said nobody should get it. Then they said no, some people should get it. And because they keep changing their minds, and not sure why, but these group of doctors keep making new recommendations, And it really caused a lot of havoc and uncertainty in the primary care doctor's offices about who should be on an aspirin tablet. But if you're at high risk or have plaque in your arteries or have established heart disease, in other words, you've already had coronary blockages or a stent or bypass surgery, you need to be on aspirin for life. And we know that there's universal benefit there and universal acceptance of aspirin. Blood pressure is tough because we'll all develop hypertension, women more than men actually, but almost all of us, if we live long enough, will develop high blood pressure as we get older. About 95% of women and over 90% of men will develop high blood pressure in their lifetime. So while we like to think we live a healthy life and we're out there doing exercise and getting out on the pickleball court or doing whatever we're doing now for exercise, and that we look healthy and we feel healthy, our arteries will slowly stiffen as we get older. And that red line is that top number, that systolic blood pressure, and that just keeps climbing with age on average. So all of us will get slowly stiffer blood vessels, and that will be reflected in a higher top number. And that top number is the most important. And when it's above 120, we start saying that that's abnormal. And if it's above 130, we start saying it's time to take a pill to lower it. So we used to have a threshold of 160 millimeters of mercury. And if you go back to the early days, blood pressure, if you ask a doctor what the full name of hypertension is, they'll say it's essential hypertension, right? Essential hypertension means that it's essential to have it. And that's obviously, we used to think that back in the early days, the normal blood pressure was thought to be 100 plus your age. So if you're 70 years old, your blood pressure should be 170 because it's essential that you have that pressure to pump blood through your system. We then realized in the 80s that if we take those patients who are running at 170 and put them on even one pill, we reduce their risk of stroke by 38%, by almost 40%, just by putting them on one pill. And if we control the blood pressure, that benefit's even larger. So what we thought of as what was essential hypertension, we need it, we now know is pathological. It's just a disease of aging. And not all people in the world develop hypertension. There's many groups, hunters and gatherers, these tribes that never get hypertension. Nobody gets hypertension. So it's clearly a westernized issue where our diet, our exercise patterns, etc., predispose us to more blood pressure and stiffening of our blood vessels. But it's eminently treatable, and therefore we can erase the risk of high blood pressure and erase that risk of ultimately having a stroke by keeping the blood pressure under good control. And now blood pressure is really easy to measure, right? There are watches that will measure your blood pressure. There are cuffs at home that will measure your blood pressure. So we can know what our blood pressure is. The problem is that the blood pressure cuffs at home are not perfect, and some people's may run differently. So if I would encourage you, if your numbers, if you have a blood pressure cuff at home or you get your blood pressure measured, not in a doctor's office, and it doesn't correlate, that you bring your cuff into the doctor and have them, and you measure your blood pressure on your cuff and then have them measure your blood pressure just to see how well correlated it is. Because the rules for blood pressure cuffs is in a room of 100 people, it's got to average out to be about the same as the sphygmomanometer, the place where we have those fancy machines and we use the manual cuffs. And it has to average out to be pretty close. But in that population of people who get their blood pressure measured, it can run 10 millimeters higher in all the men and 10 millimeters lower in all the women. And as long as the group averages out to the same, the FDA says, oh, that's fine, that's an accurate cuff. So these can be systematically wrong across the board, and you might be basing your personal decisions on a machine that's systematically giving you as an individual the wrong number. So I would encourage you, if you every time you see your doctor, it says 150, and every time you go home, it says 120 or 130, and you're saying, oh, I'm going to ignore that doctor, that's just because I get nervous, to bring your cuff in just to see what it really is on your machine when you're there. Because when you take your machine into the doctor, if it says 130 and the doctor's machine 1 minute later says 150, that's not white coat hypertension. That's a machine that's not very well calibrated for you. Again, they don't have to be perfect for the individual. They have to be perfect for a group. And that's a problem with our technology. Hopefully it'll keep getting better like everything, and we'll have more accurate blood pressure cuffs. But right now, we have to just be a little bit cautious. The other good news about high blood pressure is not only is it easy to detect and we can measure it anywhere. It's hard to go to a doctor's office without getting your blood pressure checked for any reason, is that there's a lot of treatments. And you can lose weight and your blood pressure will come down. And for every kilogram or about 2 pounds you lose, your blood pressure comes down by about 1 millimeter of mercury. So for these people who are on these weight loss drugs who are losing 20, 30, 40 pounds, their blood pressure may drop by 10 or 20 millimeters of mercury. And that might be enough to stop any or all of their blood pressure medicines over time, because obesity raises the blood pressure because there's more mass to perfuse. The heart has to work harder and the blood pressure goes up. Diet is remarkably good at lowering blood pressure. We call it the DASH diet, which is just dietary approaches to stop hypertension, but it's basically the Mediterranean diet. So the Mediterranean diet, with some salt restriction, is a very excellent diet, and it'll lower your blood pressure by up to 10 millimeters of mercury, which is what we expect a blood pressure pill to do. So you can avoid a pill for blood pressure just by adopting a little bit better diet. And 2 tricks at the bottom: sodium chloride, NaCl, is bad for you. The sodium retains water and causes the blood pressure to go up. So if you restrict your sodium, you can have a lower blood pressure. But a lot of people like that salty flavor. So potassium lowers your blood pressure. And KCl, or potassium chloride, is also salty tasting. So by substituting, it's called salt substitute. If by substituting sodium chloride for potassium chloride, you can actually lower your blood pressure between those two by another 10 millimeters of mercury on top of a good diet and on top of exercise and weight loss. So we have a lot of ways of treating the blood pressure naturally that don't even require medication, that you can adapt in your lifestyle to avoid or supplement the blood pressure pills to get your blood pressure under control. Exercise obviously is excellent for everything we're going to talk about today, but especially important for blood pressure, but it's aerobic exercise. And the U.S. Surgeon General now recommends 2.5 hours a week, which is probably more than you need to do to get the full benefit of exercise. We usually talk about 90 minutes a week or 30 minutes 3 times a week being adequate to lower your blood pressure, but more is better to some degree for lowering your pressure. So it's fine if you want to take a walk, but it can't just be a stroll. You've got to get your heart rate up a little bit. You've got to be working a little bit when you're walking through the neighborhood to get that heart rate up. That's aerobic exercise. And we're trying to exercise the heart. And by doing that, we lower the blood pressure more than if we do weightlifting or other types of exercise. Alcohol is probably good for the heart at moderation. So the people who live the longest are people who drink moderately. That's it's a little sexist, but it's 1 drink for women per day on average, 2 drinks for men on day per average. Those are the guidelines. I didn't have anything to do with it, but those are our guidelines. But you can't catch up on the weekend and say, I didn't drink this week, I'm going to have a bottle of wine or a 12-pack of beer to celebrate. But modest alcohol consumption, actually, people live longer than people who either abstain from alcohol or people who drink heavily. Dr. Gaucher-Hill spent her career in the emergency department seeing the ravages of too much alcohol consumption. We used to have across the street from Harbor Hospital, there's a pharmacy there now, but it was called Anchor Liquor. And they had patients from the emergency department. Physicians knew these patients because they lived somewhere between Harbor and Anchor Liquor. They would go into Harbor, get detoxed, and then walk across the street and get drunk. And obviously that's not good for any of your heart health. But it's important to recognize that too much alcohol will also raise the blood pressure. So alcohol in moderation is considered to be excellent and will help reduce blood pressures as well. What about cholesterol? So cholesterol, we talked about the LDL, the bad cholesterol, and the HDL, the garbage trucks, the good cholesterol. We want the good cholesterol to go up and the bad cholesterol to go down. The third component of that are the fats. Those are what we call triglycerides, and those are also a bad player. And patients who have diabetes, or what we call prediabetes, tend to have high triglycerides, and that tends to work against your heart health. Losing weight, again, another benefit, not only of feeling well, less joint issues, lowering your blood pressure, as we discussed, will also improve your cholesterol panel. So for many reasons, we want to work against this obesity issues that we see more so in the US than other countries, but certainly not far behind the world for other issues. Diet, mostly for cholesterol, it's decreasing carbohydrates. So if you decrease carbohydrates, you will have a reduction in your cholesterol more than reducing fats. So we used to think a low-fat diet was the best. American Heart Association used to always say, just a low-fat diet. But if you have a low-fat diet, you can eat a lot of carbohydrates that don't have a lot of fats, and then your body converts the carbohydrates, the extra calories, into fat. And the reason is because the body is designed to say, well, you might go through days or weeks like a lion without finding food. So when you find food, we better store it up for a rainy day or for a week of not finding another food source. We don't seem to have that problem as Americans. We don't seem to have that problem of finding the next food source. And 4 hours later, we have our next food source and we're fine. So the body keeps storing all of that excess calories for a rainy day, and the rainy day never comes, so it just turns into fat. So carbohydrates are the enemy, and we have to find healthy ways of reducing carbohydrates. Exercise, again, not only great for blood pressure, but great for cholesterol. And again, 90 minutes total a week is probably enough to get most of the benefits of exercise. And I have to counsel a lot of my endurance athletes that they're doing too much, because when you over-exercise, you end up with harm to the cardiovascular system. You have to remember the first person who ran a marathon in Marathon, Greece, died on the spot. So it was an inauspicious start to a new sport, and probably more than the normal human body can endure. But it's also probably, even for those trained athletes, they end up getting a lot more heart disease as they over-exercise. A lot of trauma to the body, to the joints, inflammation. Bouncing is probably not great for the vasculature. So long-distance runners, all of that ends up adding to harm to the body. So brisk walks, a bicycle, swimming, probably the best approach to exercise. And you don't have to run marathons or swim the English Channel to get the benefits of exercise. We have cholesterol medicines. I mentioned the statins. This is in a patient population that we used to not even think we needed to treat. These are patients with just mildly elevated cholesterol. Their cholesterol was just a little bit up. Their LDL cholesterol wasn't even in the abnormal range. It was above 100, which is now abnormal, but back in the day it was considered normal. And by taking a statin, this was rosuvastatin, or what we call Crestor, it lowered events by 44%. Almost half of all heart attacks, strokes, and cardiac deaths that occurred in the placebo group didn't occur by them taking one pill a day in the morning or night. And the benefits of statins were expanded to primary prevention, to people before they had their first heart attack or stroke. Obviously, once they have a heart attack, everybody, if you come into a harbor, if you're brought in by ambulance from Palos Verdes or Manhattan Beach or anywhere in the South Bay, you're going to come to harbor probably most commonly for your heart attack. We're going to put you on a high potency statin, a torvastatin 80 milligrams, the minute you get into the emergency department. It's now part of our emergency department guidelines to start a statin right away because we know that there's benefit for the heart. But this study shows that there's benefit even if you haven't had a heart attack yet in preventing the first heart attack. So that's what we try to do. We call it primary prevention. We're trying to prevent the first heart attack. And I call myself a preventive cardiologist because I work mostly with people before their first heart attack to prevent them from ever having that, because 1/3 of all heart attacks die from that first heart attack. So I don't want them to have that first event and not survive and then say, I could have given them medicine, but it's too late now because they're dead, right? So we try to do it in advance. And we don't think of it enough, but I think doctors need to be more proactive. This is a guy who comes in, a patient who comes in on the desk there and his back hurts. He just fell off a wall. And we want to deal with the primary question. We want to remind him his crack can be fixed. We can take care of your back pain, but it's your cholesterol that worries me. And obviously we need to think about that more in the setting of seeing patients for other reasons. I do, as a preventive cardiologist, get a few people who say, oh, my cholesterol is really high. I want to get it down and I want your help. But most people don't come to see me because of high cholesterol. They come to see me because they have chest pain or shortness of breath or some other symptom. And we have to think about treating their long-term conditions as part of our good health activities. So we talked a little bit about diet, exercise, and smoking cessation. These all play a huge role. So D in the ABCs, C is cholesterol treatment, the statins, D is diet. And we talked a little bit about diet. I'll show you a little bit more. E is exercise, which we talked a little bit about. And then not in our alphabet soup here is smoking cessation, but it's important to get people off of, to get them to quit smoking. And fortunately, there's a number of great tools available for people who really want to quit. So the American Heart Association came out with what we call a top 10 of recommendations for heart health. And I'm just taking a few of them. Some of them we've already covered in other capacity, but this is what they say about a diet now. And this is much different than the old American Heart Association, just avoid eggs and avoid meat and you'll be healthy. They talk about a healthy diet that emphasizes vegetables, fruits, nuts, whole grains, and minimizes red meat and processed red meats, carbohydrates and sweetened beverages. So it's really important to keep in mind. And the diet that's most commonly emulated or that fits this the best is called the Mediterranean diet. And we learned about the Mediterranean diet from these things called blue zones. You might have heard of blue zones. Blue zones are where people on average live longer than other groups. And most of the blue zones in the world are focused around the Mediterranean. So the more fish, less red meat, but you can still have both. More grains, alcohol is included in that. They drink a lot of wine there. That's fine. Olive oil is excellent. Nuts are excellent. So we've learned that some things, like people would say, oh, nuts could be fatty or oily. And I'm not talking about peanuts, but more like cashews or almonds or other healthier nuts. But nuts are generally considered excellent for your health, even though they might have a little bit of calories in there. I'm not a big fan of coconut. There was a fad for a while with coconut milk or coconut oil that people were adding to their milk, and their LDL cholesterol, their bad cholesterol, would shoot up dramatically. So coconuts are probably not great for you. Macadamia nuts, although I was just in Hawaii yesterday or day before, maybe it was yesterday or day before yesterday, I was in Hawaii, I don't remember, I think it was yesterday. I flew back, but I was just in Hawaii. I love macadamia nuts, but I wouldn't make them a regular staple because there's just a lot of fat in that nut and they're not ideal. But here's our recommendations overall. So vegetables, fruits, legumes, nuts, whole grains, recommended to decrease your risk factors for heart disease. And you want to replace saturated fat with polyunsaturated fats and reduce the amount of cholesterol. And sodium can be beneficial depending on your situation. Processed red meats, so those fans of deli meats getting a hard rap now, are giving our children bologna and salami every day. Probably not ideal. There's a lot of preservatives and a lot of fats that are put in there in those packaging to make it part of it, to make it harmful. So here's the evidence for the Mediterranean diet, and this is event-free survival, meaning you want to stay at the top, meaning you have no events. And much higher to the top is the Mediterranean diet compared to a prudent Western diet, which was the American Heart Association low-fat diet. So when you compare the Mediterranean diet to a low-fat diet, patients did much better with the Mediterranean diet. So again, I'll show you what that looks like, but very nice. And then there was another study, there's a second trial now done, again, the Mediterranean diet. These are now event rates, so we want to be on the lower side of who has an event. And you can see whether you supplemented the Mediterranean diet with nuts or with extra virgin olive oil. EVOO is extra virgin olive oil. I don't know why the first press of olive oil is so much better than the second or third or fourth, but extra virgin olive oil or nuts resulted in a much better outcome than a regular diet, a prudent diet that was given in these trials. So again, just more on the same, but and then at the bottom you can see meals are, this is from the original description of the Mediterranean diet, meals are ideally accompanied with a glass or two of wine followed by a long vigorous walk. So nice way to think about that. Wine actually lowers your blood pressure a little bit in moderation because it relaxes people, and that usually takes a few millimeters off. If you drink a lot of alcohol, you get that fluid expansion and your blood pressure goes up. So there's a balance here. So there's a lot of diets that have been recommended. We don't have a lot of science. These are all small studies, but there's plant-based at the bottom, what we call the Esselstyn diet, which is all plants and no proteins or no meats of any kind, no animal products. That poses a bit of a problem of getting what truly are essential omega-3s. The omega-3s are good fish oils. We need them for brain development, for eye development. They're good for the heart, and they're only found mostly in fish. So if you eat a plant-based diet, it's hard to get a good amount of essential amino acids and essential omega-3s. Pritikin was a very strict diet. Ornish was even more strict diet. 7% fats, only non-fat dairy, no fatty oils such as olive oil or avocados. We've come around from olive oil being bad to olive oil being good. There used to be, the Mediterranean diet was first described as no olive oil, avoid olive oil, and that's what Ornish did back in the day. He was a cardiologist up in Northern California in San Francisco. Now we know that olive oil, as I showed you, is beneficial. So we're still learning in the field of diet. And then there's this other fad called intermittent fasting. Intermittent fasting means that you eat all of your meals within a confined period of time in the day, 6 hours, 8 hours, and you don't eat those other 16 hours, and the body has a chance to burn off the calories and to change its metabolism without getting ramped up by having food on board. Food activates a lot of different hormones in the body when you eat. Insulin and glucagon and all of these different hormones go up and down when you start eating. And those activate bad factors. Insulin goes up when you eat because it tries to lower your blood sugar as you're eating calories, but insulin's bad for the heart. So restricting the amount of time that things like insulin are on board and elevated makes sense. And there are some, it's called time-restricted eating or intermittent fasting, and that is becoming more of a fad. Again, no big studies to show benefit, but small studies show that it's beneficial. So that might be something that we move towards. Instead of having breakfast, lunch, dinner, and an evening snack, we might try to have maybe 2 meals a day. Have lunch and dinner, or even a late breakfast and an early dinner, and don't eat after that. This is from one of the more recent articles that came out last year, and they looked at intermittent fasting, and they did find this time-restricted eating group did better. Their body weight got better. They did lose more weight. So again, this is, there's other issues at play here, but it probably makes sense to try to restrict the number of hours we eat in a given day. So I'll finish up going back to our ABCs. A is aspirin. Again, not for everybody if you're healthy, but many of us probably need it. B is blood pressure. No longer is the number 120/80. The optimal blood pressure now is considered 115/75. And there's probably no problem with low blood pressure unless you get dizzy or symptomatic. If you look at young, healthy, especially young, healthy women or children, teenagers, their blood pressure might be 90/60, and they're very, very healthy people. So low blood pressure is not a bad thing unless you're getting dizzy from having your blood pressure being too low, and that's pretty rare. There is at least one medicine I know of that will help raise the blood pressure, but it's very rare and we rarely ever have to use it. So lower is better. Cholesterol, lower is better. Diet, obviously weight loss and restricting some of the carbohydrates and some of the saturated fats are probably a good idea. Exercise, again, 30 minutes 3 times a week is adequate to get the cardiovascular benefit. More than that is probably good, but up to 45 minutes. If you go too high on exercise, over too many hours per day, you actually just invoke more risk of both heart disease and orthopedic injury by over-exercising. And then F is probably at least fish, and there is some good science on specific fish oils that may be very helpful to help us with our heart. So let me just, this is the recommendation for exercise, one of those American Hearts, but this is how we see people a lot. What do you mean you're out of breath? I haven't turned the switch on yet. So we have to get patients to be willing to move a little bit even. And it doesn't have to be running a marathon, probably not a good idea, or doing a high intensity aerobics, but just even taking a brisk walk. But you do want to get your heart rate up a little bit. So if you have one of those smartwatches, you do want to see your heart rate going a little bit higher, at least into the 90s or in the 100 range. It doesn't have to go super high, and it should never go higher than 220 minus your age. That's your upper limit of heart rate. So I have some exercise nuts who they're 70 years old, they're trying to get their heart rate up to 180, and that's just probably very bad for them in the long run. They can make claims of how great they are and how fit they feel, but it's probably harming the body by going too fast. So 220 minus your age is the maximum your heart rate should ever be when you exercise. And it probably does it, and then our target is actually 80% of that. So you have to do a little bit of math, but 80% of 220 minus your age is your target heart rate for exercise. And there's a lot of different exercises that help with this. We talked about already. And if you look to the right, that's good for you. And or if you don't hit those numbers, that's bad for you. And a lack of physical activity is worse, more to the right, than high cholesterol is. So lack of physical activity, it's almost as high as smoking to the right. Not as high as diabetes or hypertension, but it's a big risk factor to not exercise. And it's almost as powerful as it's more powerful than having high cholesterol at predicting who's going to have a future heart attack or stroke. So it is an important risk factor. So again, if you're working a lot and you're in the office, or people who spend too much time sitting at their desk, a standing desk is one simple approach, but taking a little walk at lunch or at breaks, getting a little exercise, even things like jumping jacks or other things can be done in the middle of the day to help get moving. This is just, don't sit around, walk your dog. Don't take the elevator, take the stairs. Don't sit down, move and meet people. You can see about 10% less chance of dying in patients who just do simple things on a daily basis. So this has been our evolution. We started getting taller and thinner and stronger, and now we're kind of going the other way over the past 50 years. And hopefully, with the help of medications and with the help of other things, no offense to the three. I showed this once at a Rotary Club meeting, and one of the guys there owned a Kentucky Fried Chicken restaurant. He was not very happy, so I apologize if I offend everybody. I do like Kentucky Fried Chicken, though, for full disclosure, but rarely as a treat rather than daily as a meal. But we have to go beyond exercise, and we need sometimes medications, and this is so give up smoking, give up booze, give up red meat, and diet anyway. So we do need to sometimes go beyond exercise and diet to get medications, and I encourage people to find that balance that's they're comfortable with, but also gets them to their goals. So with that, I will stop. But this is our argument for prevention. This is probably the father of preventive medicine. His name was Sir Geoffrey Rose. Being healthy is better than being sick or dead. That is the beginning and the end of the only real argument for preventive medicine. It is sufficient. So we want to keep people healthy, and that's really what our long-term goals are in the world of prevention. So I'll stop here and thank you all for paying attention and be glad to answer any questions.